Great. Well, welcome. I don't know. How many people do we have? A lot of people?
It says we have 10 participants
Oh,
and
great.
people will rewatch later too.
Yeah, no problem. So I'm going to I picked three articles and I'm going to kind of go over and then also go briefly over how I kind of read an article and kind of what I'm looking for when I read an article and some like thoughts and then, plenty of time. So for questions. I shouldn't take very long. So if people have questions, they want to ask about stuff, want to ask about the articles, whatever, um, just interrupt or send it in the chat or whatever. So outline. I'm going to talk about three articles. We're going to go over basically the title of the article, the PICO of the article, a little bit of a critical appraisal, and then kind of like the take-home message after every article is like, should I change my practice, or should I incorporate it in my practice, or whatever. So things to keep in mind. Scientific inquiry has to be disinterested. So regardless of whether it's your paper or you're reading somebody else's paper or whatever, you really can't be emotionally, economically, professionally, you can't be invested in a particular outcome other than the outcome of the truth. So that sounds easier to do than it actually is, but you just have to kind of remember to be totally disinterested as to what the actual outcome of the study is. And then the goal of critical appraisal is not to like segment papers or articles into good articles and bad articles. Really, it's giving us an idea of how much we should change our practice based on the results presented in the paper, and that's really it. So it's not a reflection of the quality of the science in the manuscript, and it's not a reflection of the quality of the scientists who wrote the manuscript. It's really just a way for us to gauge how much we should change our practice based on the results that they presented. And it's important to remember that when we critically appraise articles, that research is difficult to do and is limited by numerous factors that are totally outside the researcher's control, that limit the amount or the type of data or manuscript can be presented. So sometimes we see an article and we say, well, it doesn't really tell us much about what we can do for our practice or about the disease. That still may be the best possible article that could have been written. It may just be a limitation of the disease. So we're going to every time you read an article, you should be like critically and skeptically appraising it, but only the data in that, not the people who are writing it, which is an important difference. And then the PICO format, hopefully everybody's familiar with this, but I think it's a really good way to organize your thoughts when you're looking at an article or anything else. And so just a reminder, because I'm going to use this format to kind of look at these articles. So the first one we're going to look at is this one: long-term pain relief at 5 years after medical repeat surgical procedures, no management. I don't know if everybody had a chance to read the articles or not. I left the authors off on purpose, but I think everybody had access to these. And so basically what they were looking at in this study is patients who had a successful MVD, and it's important that it's not all patients who had MVDs, it's patients who had MVDs and got better at a single institution over 20 years, who returned a questionnaire 5 years after their surgery. So it's, very specific patient population. And what they're looking at is preoperative characteristics or lack thereof. So they're looking at kind of like how the patients presented and whether they could predict recurrence of their pain after they had a microvascular decompression that was initially successful. And so you can see it's always good to look at the end of the introduction, because that's usually where you'll find their hypothesis and their aims. So what they were actually looking to evaluate. And so they thought that patients who experience recurrence after MVD will have distinguishable characteristics preoperatively that repeat operations will provide better pain relief than medical management. So we're going to talk about kind of that first aim in the study. So basically this is their first, so this same paper, and this is their table 1. So you can see you have patients in whom pain recurred, and then you had patients in whom pain did not recur. And their hypothesis was that some of these factors would be different and help them predict who was going to have a recurrence and who wasn't. And so what I hope you can see is that that didn't work out. That all these characteristics were basically the same between the two groups. And then they use kind of this NS is non-significant, and then they give us a chi-square value, which we're going to talk about a little bit later. but it's funny, and you don't often see chi-squareds reported in the literature. We'll kind of go over why that is, why it's kind of funny to report a chi-square, I think. And then they had a second outcome, right, where they wanted to see whether or not patients who had a successful MVD and then recurred, whether a repeat operation or no therapy or medicine would be better. And so so that's what they're looking at in this table, or in this figure 2 from the paper, where they kind of showed, the dark, no pain versus pain. And so they made kind of the argument that repeat operations are better for pain recurrence than medical therapy or no pain therapy. So what are the limitations? So if we look, they had 284 patients actually underwent a microvascular decompression at the center over that period of time, which is a good number, but only 169 had data that could be included in the study. So already you're losing over 100 patients, or over a third of the patients. So you've got to worry about, when you have that many patients not included in the final analysis, was the loss to follow-up non-random? For instance, I'm just, you can just make up reasons, but if you can conceive of a reason why the loss to follow-up might not be random, then that has to tell you you have to kind of interpret the results with a grain of salt. So for instance, if everybody who didn't respond, if everybody who died basically during the follow-up period died from suicide due to their recurrent face pain, and they're not included in the analysis, well, that's an important loss to follow-up, right? And so, like, that's just an example. It's kind of a silly example, but it's an example of why loss to follow-up is so important. There are heterogeneous groups of patients, so they might not always be the same, right? And so patients who have a recurrence are not the same as patients who don't. And so maybe we're just, comparing apples to oranges. The preoperative characteristics are samples of convenience, so they can only look at the stuff that they measured. And so they said, it's got difficult to manage and has unclear predictors, but maybe it does have very clear predictors. They just never recorded any when they were setting up the study, which is probably more likely to be the case, which is a problem with doing retrospective studies when you don't prospectively gather the data on purpose. There's no way to determine why the management strategies were chosen. For instance, in the patients who had recurrent pain, if everybody who had anesthesia dolorosa was given medical therapy or no therapy, that's going to dramatically alter the success rate, because anesthesia dolorosa is kind of like the most difficult recurrent face pain there is to treat. And so if all those patients in an unblinded way got one therapy, that's going to make whatever therapy they were assigned to look the worst, just because of the small numbers involved in the severity of that disease. And then if we look at this figure 2, where they reported a significant difference based on the chi-squared, but we convert it to kind of a more typical result, where we look at odds ratio, and we use a Fisher's exact test because the numbers are so small. I did this. I looked at the data from the paper and redid their statistics. And so if you do it and you use a Fisher's exact test, which is a more conservative estimate of the p-value, you find that the p-value actually is not significant. So the only significant difference they report actually lost its significance when you redo it with a Fisher's exact test. So, I can see why they did it, the chi-squared, that way, because when you make a table and you have 3 predictors, basically, like you have 3, it's like a 2x2 table, but sometimes it becomes a 3x2 table. And if you're going to do a 3x2 table, the mathematics of getting an odds ratio become a lot more complicated, but the chi-squared value is easy to compute. But then it begs the question, why did they group in MVD with like radiofrequency percutaneous rhizotomy? Like, why are those two grouped together? But like they didn't group together no treatment and drug therapy. So why group all surgery together, but then not group no surgery together? And I guess the most skeptical or cynical reason to do that is you only report the data grouping that gives you a significant p-value. which obviously raises a chance that the difference that we see is due just to random chance. That's kind of that issue of p hacking or alpha spending or whatever you want to call it. So those are my thoughts on that article. I don't know if anybody wants to join in the chat, if anybody read it, or if they have thoughts about what we went over, or if they thought like how would this change your practice. I understand you guys are, I think, almost all medical students, or all medical students, so you don't really have a practice yet, but you can imagine what you would do. So kind of, if anybody wants to volunteer or chime in about the article or thoughts or questions or whatever before we move on to the next one. All right, I just got the chat open. Sorry, I'm a little bit of a grandpa. With the p hacking issue, do you think that it'd be harder to publish a study with the conclusion that repeat surgery does not improve outcomes? It seems to be equally state. Yeah. So yeah, I mean, I think that's a good point. And certainly there's a bias in the literature, especially when you have a small study, to publish small, if it's a small study with a kind of a minimal result. If it's not positive, it's not going to get published. And so that's the issue. Would the journal not catch that before accepting the manuscript? So that's from the Q&A. You would think so, although again, sometimes, so there's two kind of like thoughts, right? So one, sometimes the journal or the editor, the reviewers will, and I review articles, and I'm kind of much more of a sieve than I am a gatekeeper when I review articles, in that we're all capable of reading this article and kind of drawing out what we think is appropriate data and what we think is inappropriate data, and how it's going to change our management or our decisions. And so I kind of am on the side of let the reader decide. There are pros and cons to that approach. The pro is that you get the maximum amount of scientific literature in the hands of the people who can use it, but it relies on the assumption that you have an educated readership. The alternative approach is to be a very strict gatekeeper and only let in stuff with a very low risk of bias and a very high rate of changing your practice or confirming your practice. But the downside of that is that you're kind of all the gatekeeping. You're doing all the gatekeeping behind the scenes, and so your readership doesn't really get the chance to decide. Another Q&A: with a sample size of 284, what would you therefore consider to be a large enough sample size that would not need parametric statistics? So I'm just going to go back on my slideshow. So if we look at 284, number one, if we're going to do parametric statistics, we need a continuous variables, no matter what the sample size. So none of our variables here are continuous. They're all like categorical, like this surgery or that surgery or this surgery or that surgery, or your pain got better or it didn't, or it recurred or it didn't. And so all of those are going to kind of limit the amount of like classical t-test parametric statistics that you can do. Number one. Number two, the p-hacking reason I use the Fisher's exact test is if you look at this graph, that the odds ratio that I put up is just based on the graph in figure 2. So if you count up the patients in figure 2, you can see that it's actually very few. And that's because of the patients who had a recurrence, there were only, I think, like 28 patients total who had a recurrence. And so this data that they did the odds ratio or that they did the chi-square on, like which treatment is better for recurrent pain, is actually based on a very small sample size. and each individual cell of your 2x2 table is under 10. And so that's why I think you need to use a Fisher exact test rather than a chi-square. That's why I use the Fisher's exact test. Now, it's never important to know, it's never wrong to use a Fisher's exact test. It's the only reason the chi-square test exists is because the math to do a Fisher's exact test by hand, which large numbers, is very tedious and difficult to do. And that's why they use the chi-square test. But in the era of computer statistics, there's not really a reason to use a chi-squared other than historical, and other than the fact that at large numbers, the answers are so close between the two tests that it doesn't really matter which one you pick because they give you the same answer basically with large numbers. But it's never wrong to use a Fisher's exact test. So does that answer the question? I hope so. I felt like I answered it, but okay, awesome. All right. So let's go on to the next article. All right, so this is diffusion tensor imaging reveals microstructural differences between subtypes of trigeminal neuralgia. Important to note, when just some background, I know you guys have had a lot of learning about trigeminal neuralgia, and a key part of that is a Burchell classification. And so trigeminal neuralgia type 1 is when more than half of your pain is the lancinating electric shock type pain. And trigeminal neuralgia type 2 is when more than half of your pain is a constant burning, typical neuropathic type pain. And so both of those groups together, trigeminal neuralgia type 1 and type 2, in the old-fashioned grading system, which is what a lot of people still use clinically, will be considered classic trigeminal neuralgia. So the reason that they're interested in type 1 and type 2, Burchell type 1 and Burchell type 2, is because those are the patients that traditionally would be called classic trigeminal neuralgia or tic-Dolerou. Everybody else, 3 and up in the old scheme, would be called atypical face pain. But in Burchell classification, atypical face pain is synonymous with psychogenic face pain. And so it's important to know those differences as far as that goes. So 15 patients with idiopathic trigeminal neuralgia. They started out with a lot more, but if you read how they winnowed down the MRIs, the final sample group was 15 with idiopathic trigeminal neuralgia. They had either a positive test on the diffusion tensor imaging, we'll talk about that in a second, or a negative test. And then they wanted to know whether you could separate, whether you could identify or diagnose trigeminal neuralgia type 1 versus trigeminal neuralgia type 2 based on the clinical history. So this is a diagnostic study. We were trying to diagnose something. And so the gold standard is clinical criteria for Burchell clinical criteria that we just went over. So I have like 10 windows open with the Zoom. So let's see. Okay, so basically they did this ADC and RD measurements from the DTI. And what they compared, if you look at this figure C with the receiver operating characteristic, they compared trigeminal neuralgia type 1 to trigeminal neuralgia type 2 and controls lumped into one group. And so what happens when you do a diagnostic test and you compare it, well, let me ask if anybody wants to be brave and either type it in the chat or unmute themselves. But how does the inclusion of controls in a diagnostic study change your interpretation of the results? Anybody?
Someone, I think, raised their hand, so I'm going to allow them to talk.
Oh, yeah, go ahead. Sorry.
Okay. Go ahead, Corinne.
I would think that including controls would make it easier to find a difference between the two groups because I guess controls just have no pathology. So it's already like a bigger, there's already a gap there from the type 1 neuralgia group.
Yeah, so that's exactly right. A good example is I read a study looking at diagnosing like carpal tunnel. and they had like a new test to diagnose carpal tunnel, but it was people with obvious clinical carpal tunnel compared to normal controls with no symptoms. But of course, that's not a diagnostic dilemma. Like if you're going to invent a new diagnostic test, you have to be solving a diagnostic dilemma. And there's no diagnostic dilemma between classic carpal tunnel syndrome and a 20-year-old with no symptoms who works in a lab. So if you include whatever, if you're ever comparing a test to somebody who's asymptomatic, then by definition, you're going to like increase the sensitivity and specificity of your test because you're not testing groups with diagnostic uncertainty. And so lumping controls in with one of the groups is problematic in my view. And the reason being, if their justification was, if you look in figure B and you look at RD, well, they say that the controls and the type 2s overlapped. And if you look at ADC, you can see that the controls and the type 2 overlapped. But if you look at AD, you can see that the controls and the type 1 overlapped. And so there's not really, they didn't really give a convincing physiologic reason to lump them together rather than separate them. And then the other thing that's hard is if you've got a diagnostic test, right, and you want to use it clinically, you can't just rely on the receiver operating characteristic. That just tells you that there is discriminating ability of the test can discriminate things. But each spot on that curve, each like little corner on those curves is an actual value of the test. Like the RD equals X or ADC equals Y. And that's how you generate this curve. You plot the false positive and true positive rates for every individual cutoff. And as you do that, you create a curve, then you draw a line and you make a curve. But they didn't tell us what that circle was. So we don't know what value of the RD we need to be looking for to kind of separate type 1 and type 2 trigeminal neuralgia. Or more specifically, to separate type 1 trigeminal neuralgia from people with no problems whatsoever or people with type 2 trigeminal neuralgia. So it makes it really hard to use this study to make a clinical decision because you don't know the cutoff value you should be looking at. And then finally, for diagnostic tests, you have to have, well, let me go to the next slide, I think. Yeah. So in order to change your practice, you have to be solving a problem with the current diagnostic methods. So you're compared to a gold standard, you should be either cheaper, less invasive, more available, or more accurate. So you should be fixing a problem with the current diagnostic methods of the gold standard. Otherwise, why would you move away from whatever gold standard test you're comparing to? And so for this one, the gold standard was clinical criteria that you guys all know, like the back of your hands now. And so I would hazard a guess that not many of you would see a patient in clinic now with classic trigeminal neuralgia, virtual type 1 or type 2, and not be able to tell the difference. I think that I think 100% of you can do that right now. And so what is this study adding to our clinical practice? Not much, I would argue. And they have a lot of theories about why they're different, as far as like demyelination, and maybe it's demyelinating and they've got incomplete repair of the myelination. And so that's what leads to the differences on the DTI. And all that may be true, but in the end of the day, that's kind of like a just so story. A just so story, for those of you who aren't familiar with the term, is where you find a difference or something that you see as a fact, and then you make up a story to explain the fact with no evidence to support that story that you just made up, right? And just so stories like how the elephant got its trunk, or those Rudyard Kipling stories. And so like a lot of their explanations in this paper were kind of just so stories. They're interesting, worthy of investigation because they create hypothesis, but the actual specific aim of the paper to tell these two things apart, we already can tell them apart. And I'm not 100% convinced that their test is very reliable at telling them apart. So that's kind of my thoughts. Does anybody have any thoughts, questions about this paper? Disagreements, agreements, whatever, before we move on to the next one? Okay, seeing none, I'm going to move on. So next, so a novel scoring system is a preoperative predictor of pain-free survival after microsurgery for trigeminal neuralgia. So, so the P is patients undergoing an MVD or a internal neurolysis, which is kind of like, they used to call it combing the nerve. I don't know if anybody's talked to you guys about that, but so, you know, usually if you're doing an MVD and you don't see any convincing vascular compression, especially arterial compression of the nerve, then you do kind of an internal neurolysis where you kind of like dissect along the fascicles of the nerve and kind of like separate them out, and they call that combing the nerve. I personally, in my practice, I don't really do internal neurolysis. If I get to do an MVD and I don't see really convincing compression, then I'll just do a rhizotomy by doing like a mechanical crush to the nerve while I'm looking at it. And I just kind of grab it with a forceps and crush it for a second. And I think it essentially does the same thing. It's just a rhizotomy instead of a neurolysis, but that's a common thing to do. You get in there, you don't see good compression, and you want to make sure they wake up pain-free. You have to like irritate the nerve or disrupt it in some way to get them pain-free. So that's what they're talking about. So you can see kind of like there's already bias, because if you're getting an internal neurolysis, that means that your compression was not convincing or was non-existent, one of the two. Again, it's trigeminal neuralgia type 1 or type 2. You're either going to get a high score or a low score, and they want to predict pain relief. And so they had a hypothesis that pain type, presence of a vessel, severity of compression, location of compression would be the important prognostic factors based on previous articles. So I think this is a great example of like a bunch of other articles that kind of had these hypotheses that they thought were predicting what's going to happen to these patients. And all those things had pros and cons, all those articles. What these authors did was like, look, this is what people say in the literature. This is what our clinical experience tells us. Let's make a score and then put it to the test and then see if it actually works. Because sometimes, especially when you're experienced, as time goes on, you get like an intuition for the disease processes you treat after you see enough patients. And you kind of get like a unconscious understanding of who's going to get better and who's not, and what kind of surgery is going to work and what's not. And it's very difficult to articulate the specific factors that you're looking at. And so sometimes when you're looking at one factor or another, what you're actually grading, especially in a single surgeon series, is that surgeon's intuition. And so it's important to break it down to these simple scoring systems to that very much like distills the intuition into like things that are reproducible that you can learn as a medical student and a resident, and very quickly increase your skill level dealing with these diseases without needing to go through the 20 years of experience that the writers of the score did. So I think that there's a lot of value in these scores, especially for people when they're in their training. Okay, so here's a picture of the score. So, you know, basically a lower score means you're less likely to do well. They would hypothesize that a higher score means you're more likely to do well with an MVD, or internal neurolysis. And so what they did was these Kaplan-Meier curves, which are an excellent way to prognosticate, because the statistics kind of have like a built-in way to conservatively account for loss to follow-up. And so usually you see them use as survival curves, but in this case, they use it as pain-free survival, which is like a perfectly appropriate way. So they don't really have any bones to pick with their statistics. You can see that they didn't unnecessarily dichotomize their outcomes. So they didn't say like, oh, greater than 2 is good and less than 2 is bad. They went through each individual number of the score individually, and you can see almost like a dose dependent response. As the higher your score gets, the better you are likely to do with an MVD. And then they showed that they kind of, with the other figure 5, they address the confounding of, well, look, everybody, because if you were critically appraising this article without this data, you could say, well, look, everybody who got a 3 out of 3 on their score is clearly just the classic trigeminal neuralgia type 1. And what they showed here is that no. Type 1 trigeminal neuralgia symptoms are only one factor, and these other factors are actually important. And so I think that was pretty convincing, comparing the score of 1 to the score of 3. And so you know, I don't know how you guys felt. I actually felt that this was like a really good paper. It was very simple, very immediately clinically applicable. That you guys can read this paper, and then if you're in clinic seeing trigeminal neuralgia tomorrow, right after reading this, you're instantly going to be much better at figuring out what surgery to recommend when you're presenting the patient to staff, or like talking to patients. You're immediately going to be more informed, and the statistics were, I think, appropriate, and the conclusions were accurate and reflective of the results the authors reported. So I thought this was a really good study. I don't really have a lot of bones to pick with it. So love to hear anybody's thoughts or questions about this or trigeminal neuralgia in general. This I did 3 papers. So this is the 3rd one. Yeah, so feel free. Anybody has questions about like how we, why I look at papers the way I do, or about trigeminal neuralgia or anything else, feel free to type it in the chat or the question and answer, or unmute yourself and talk, whatever. Yeah. I'm trying to figure out how to do raise hand. So how do I let you talk?
Yep, I just asked her.
Okay, great. Thanks.
Thank you for the talk. This was super informative. So my question was kind of regarding your practice. I was wondering if there were any instances where you read some papers regarding a topic that significantly influenced the way that you do surgeries, and if you could tell us about that.
Yeah, I mean, so the one that comes to mind is I read a paper by from Herring Nauta's group in Louisville on the surgery called a punctate midline myelotomy for the treatment of visceral pain, which, I don't know, you guys may or may not be familiar with, but I do a lot of chronic pain, and I get very complex referrals, and sometimes those referrals are patients with intractable malignant pain from cancer. And I read that article, and then I read the related articles, and I was like, wow, this is a total game changer for me. And then, I started being on the lookout for patients who might do well with that. And now I've done a few of those procedures, and it's like a miracle procedure, honestly, if you have the right patients. And so that's an example of that. It's kind of one of those things where you're going to have light bulb moments like that, where you're like, wow, this is a total game changer. I never thought about it like that, but I definitely should do that in my practice. So that's there have been several, but that's the one that occurred to me last. And the interesting thing is that the data from, and I'm a big evidence-based medicine guy, the evidence-based medicine type data from that is like very weak. It's like case series and descriptions and stuff like that. But, it's also a little bit of a parachute problem. You have something that you see in clinic that is totally incurable, that suddenly somebody's curing with a surgery that you can do. In my opinion, you don't need to put that through a randomized controlled trial. It's more of a parachute kind of problem. Top things you look for to indicate a high quality paper. Well, I think that dovetails nicely what you're just saying. So I think a lot that goes into it, but number one, I think if they have a clear hypothesis that they're testing, regardless of the study design, and that they limit their conclusions based on the results on that hypothesis, then it's a high quality paper. So things that I don't particularly look for, I don't look for sample size. I think sample size is largely irrelevant unless you find something that the sample size, unless you think that there literally is a problem with the power in the study, then I don't think the sample size matters very much. I think that I don't look for the results. I think negative and positive studies are both, high quality studies. And again, I think in some ways, you have to have clinical experience to judge the study, because otherwise you can't really put it in the context of your own practice, which is really what's important for a physician, is to know, like, should I change my practice or should I not? If I want to look at the quality of the paper from an evidence-based medicine point of view purely, then the grading scale that I like to use is the American Academy of Neurology, the AAN scale. And that's a very simple, once you learn the metrics of it, it's very easy to apply, and you can read the method section in the paper you're reviewing and very quickly decide whether it's a type level 1, level 2, level 3, level 4 evidence. But like I said, level of evidence is just one part of what you're going to do. For instance, and we can go on and on with examples, but like the Sport 1 trial, which is before your guys' time, because it was before my time by a little bit, was a study on herniated discs and surgery, okay? It was a randomized controlled trial published in the New England Journal of Medicine that the intention to treat analysis showed that surgery for herniated discs did not help, that patients did well with conservative therapy or surgery. Level 1 evidence, undeniable. But the problem was that 70% of the patients assigned to conservative therapy then ended up crossing over to surgery. So when they looked at that, you found out that, like, the Sport 1 trial really wasn't applicable, and that the only reason they came out equivalent is because patients got tired of being in horrible pain, got surgery, and then got better, and then were analyzed as if they got conservative therapy, PT and medicine. Yeah. So that's just one example. So level of evidence is just one part of it. And so let's see, Dallas Road. I believe midline myomonitis is a very small sample size. How did you then weigh your trust performing the procedure with your own practice? Yeah. So it's kind of like we have to function as surgeons with the data that we have, not the data that we wish we had. And even in the busiest centers with the most experienced surgeons, the number of patients who are appropriate for that surgery is going to be incredibly small. And so you really have to use your best clinical judgment, unfortunately, and go from there. And then as far as publications, yeah, absolutely. I think there's ways to synthesize that data that's new and interesting that I'm working on, both my own data and like the stuff that's been published, to see how much it helps, for sure. But it's just the limitations of that, and it's the same for everything. If you wanted to look at the value of, say, endoscopic endonasal clival chordoma resections, and you're waiting for a double-blind randomized controlled trial, it's never going to happen, right? It's just never going to happen. It's too rare of a problem. And one of my old mentors had like a little chart of cancer, brain metastasis cancer therapies, and if you were going to evaluate them in a double-blind, placebo-controlled, randomized trial before you did any of these interventions, surgery plus radiation, whatever, he showed that you would need a population with metastatic brain cancer greater than the entire population of the planet to have enough power to solve the question. So there's just realistic limits in what you can evaluate with kind of these randomized prospective controlled trials. And so you have to, that's when you have to use your experience and kind of the art of surgery, because the data is never going to come. basically.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.